Antibiotics have transformed the care of cancer patients, enabling the prevention and treatment of once lethal infections during chemotherapy and transplant. In order to continue to ensure progress in cancer care, it is absolutely critical that we begin to think about ways in which we can optimize antibiotic use in this population. Our topic today is to discuss the management of neutropenic fever within the framework of antimicrobial stewardship. I have no disclosures. The objectives for today's presentation are to describe opportunities for antimicrobial stewardship in neutropenic fever. We will review the current guideline recommendations for antibiotic de-escalation and also describe antibiotic de-escalation strategies reported in the primary literature. I will begin by providing some background information, review of guideline recommendations, and the existing literature. Dr. Nagel, in his talk, will then discuss real-world experiences with de-escalation strategies at his institution. Neutropenic fever is a common clinical syndrome encountered among cancer patients and occurs in 80% of patients with hematologic malignancy and up to 30% of solid tumor patients. Mortality rates range from 8 to 14%. Febrile neutropenia is considered an oncologic emergency and is a model example to illustrate the importance of antimicrobial stewardship principles in the management of the cancer patient. First, it is absolutely critical to ensure early recognition of this diagnosis to allow for early administration of the right drug at the right dose at the right time. At the same time, it is also important to consider the duration of therapy and how antibiotics can be modified or de-escalated as the patient's clinical course evolves. To review some basic definitions, fever is defined as a single temperature equivalent to 38.3 orally or equal to or greater than 38 orally over a 1 hour period. Neutropenia is defined as an absolute neutrophil count of less than 500 or an absolute neutrophil count of less than 1,000 and predicted to decline to less than 500 over the next 48 hours. One of the biggest challenges in the management of a patient with neutropenic fever is diagnostic uncertainty. An infectious source is identified only among 20 to 30% of patients who present with neutropenic fever and may include bacterial, fungal, or viral etiologies. However, the vast majority of people with neutropenic fever fall into the category of unexplained fever, and I will focus on this particular group later in my talk as we discuss de-escalation strategies. There have been changes in the types of bacterial pathogens seen among neutropenic patients over the past 50 to 60 years. In the 1960s to 70s, with the introduction of cytotoxic chemotherapy, gram-negative organisms predominated. There was a shift towards gram-positive organisms in the 1980s to 2000s with the routine use of central venous catheters and use of antibiotic prophylaxis against gram-negative organisms. Over the past 2 decades, we have seen the emergence of drug-resistant organisms, and in particular fluoroquinolone resistance due to its use at many centers for antibiotic prophylaxis, resulting in a shift back to gram-negatives, in particular those with resistance to fluoroquinolones. There was interesting data presented from a multi-center study at ID Week in 2018, indicating that the proportion of gram-positive and gram-negative blood isolates among patients presenting with a first episode of neutropenic fever was essentially equivalent, representing a shift away from the gram-positive predominance seen in prior reports. These trends underscore the need for optimizing the way we use antibiotics in these patients. There are a number of potential stewardship opportunities when managing a patient with neutropenic fever, and today I will focus on 2 areas, including use of vancomycin as empiric therapy and for management of patients with persistent neutropenic fever, and then I will focus the rest of the discussion on antibiotic de-escalation. I will walk through a case to illustrate some of these opportunities. The patient is a 63-year-old man with AML who is status post-induction chemotherapy and who presents with fever and neutropenia during a blood transfusion. He has no other associated symptoms, and you can see that he has a temperature of 38.6. The rest of his vital signs are normal. He does have evidence of severe mucositis on exam. His Fickman catheter site does not have any erythema. He is receiving standard prophylaxis with levofloxacin, fluconazole, and acyclovir, and he's been neutropenic for about 10 days. So the question is, what agent would you choose as empiric therapy? Vancomycin alone, cefepime alone, the combination of vancomycin and cefepime, or no antibiotics should be initiated and await blood culture results. The fever is most likely due to his blood transfusion. The correct answer here is cefepime alone as monotherapy. Due to the high risk of infection in this neutropenic patient, choice D is not an appropriate response, and empiric therapy should be given while awaiting further diagnostic workup. We will discuss the role of vancomycin over the next few slides. Should vancomycin be used for neutropenic fever? The 2010 IDSA guidelines on the management of neutropenic fever, as well as the NCCN guidelines, do not recommend initial use of vancomycin for empiric therapy of neutropenic fever, with the exception of selected situations, which I will discuss on the next slide. These are A1 level recommendations based on randomized controlled trials demonstrating no benefit in terms of fever duration or mortality. If vancomycin is used, the guidelines recommend stopping vancomycin after 48 to 72 hours if cultures are negative for resistant gram-positive organisms. Indications for empiric use of vancomycin according to three different guidelines: the 2010 IDSA guidelines, the 2011 EASL guidelines, and the 2020 NCCN guidelines are shown here on this slide. You can see that there are some differences by guideline, but there was in general a consensus to use empiric vancomycin among those patients who have clinically apparent serious catheter-related infections, hemodynamic instability, a history of MRSA colonization, and skin or soft tissue infections. For this particular patient, although he had severe mucositis and received fluoroquinolone prophylaxis, the choice you were given was cefepime and not ceftazidime. The key difference between the two drugs is that ceftazidime has weak gram-positive coverage, in particular with limited activity against viridans group strep, in contrast to cefepime, which has excellent coverage of viridans group strep and thus can be used as monotherapy to provide activity against this organism as well as gram-negatives. Several studies suggest that there is excess empiric vancomycin use in neutropenic fever. In a retrospective cohort study of patients with neutropenic fever, 63% of patients had an inappropriate indication and/or duration of vancomycin use. In a large cohort of over 25,000 solid tumor patients who were admitted with neutropenic fever, 37% received vancomycin inappropriately, with increased empiric vancomycin use observed over a 10-year period. Returning back to the case, after 72 hours, the patient remains clinically stable but is persistently febrile and neutropenic. The patient has multiple blood cultures, which are negative, and cefepime is subsequently brought in to meropenem, and vancomycin is added. Is there a role for adding vancomycin to an anti-Pseudomonal gram-negative among patients who have persistent neutropenic fever? This question was evaluated in a multi-center randomized double-blind randomized controlled trial that was published back in 2003, where patients were with persistent fever after 48 to 60 hours of empiric piperacillin tazobactam monotherapy were randomized to receive either vancomycin or placebo. You can see in this figure that there was no significant difference with respect to time to defervescence, and additionally, there was no difference with respect to further episodes of gram-positive bacteremia or mortality among those patients who received vancomycin when compared to placebo. Both the IDSA and NCCN guidelines do not support routine antibiotic escalation among stable patients with unexplained persistent fever. The IDSA considers this an A1 level recommendation, and the NCCN discourages random additions or changes in therapy in the absence of clinical or microbiologic data. It is important to remember that the median time to defervescence is approximately 5 days among patients with neutropenic fever despite receiving appropriate therapy. The only exception is to consider empiric antifungal therapy among high-risk patients who have persistent fevers after 4 to 7 days of empiric antibiotics, particularly if they are not on mold-active prophylaxis. Returning to the case, finally on day 5, the patient becomes afebrile and continues to remain clinically stable. The patient is still neutropenic, and blood cultures remain negative. Vancomycin is discontinued, but meropenem is continued. So here we have a patient with neutropenic fever of unknown source who has defervesced. And the question that has come up is, how long should this patient be treated for? Well, the answer is, it depends. The answer is fairly straightforward if counts have recovered. Typically, the conventional approach has been to discontinue therapy at this time. However, how does one manage the patient who is still neutropenic when fever has resolved? The traditional approach has been to continue the current regimen until the ANC is greater than 500. The rationale for this approach is that the risk of infection is considered to be significant among people who have continued neutropenia. Whether antibiotics can be safely discontinued at an earlier time point has been an area of controversy. There have, however, been more recently data to suggest that de-escalation and even discontinuation may be a safe approach with similar outcomes when compared to continuation of therapy until count recovery. The original recommendation to continue antibiotics until count recovery is based on some early studies, including a small randomized controlled trial published about 40 years ago now in 1979 of 33 patients with neutropenic fever of unknown source, who were treated with 7 days of empiric antibiotics and who were afebrile and neutropenic at the time of randomization. The patients were randomized to either continuation of antibiotics until count recovery or to discontinuation of antibiotics at day 7. As you can see, the outcomes of those patients who had their antibiotics stopped were worse compared to those who had their antibiotics continued. There were higher rates of recurrent fever, documented infection, and mortality, which was 12% compared to 0% among those who had their antibiotics continued. Based on this study and a few other small studies, the 2010 IDSA guideline recommendations indicate that for patients who have unexplained fever, it is recommended that the initial regimen be continued until there are clear signs of marrow recovery with the ANC of greater than 500. This is given a B2 level recommendation. And the guidelines also comment that years of experience have proven that this approach is safe and effective. The guidelines do offer an alternative approach and state that if an appropriate treatment course has been completed and all signs and symptoms of documented infection have resolved, patients may resume fluoroquinolone prophylaxis prior to ANC recovery. However, they do not provide any specific details on what constitutes an appropriate treatment course, and this is given a C3 level recommendation, which represents the lowest evidence grade and strength. However, since the PISO study in 1979, there have been a few studies that suggest that early antibiotic de-escalation may be a reasonable approach in selected patients. In a small randomized controlled trial of pediatric cancer patients who were deemed to have low-risk neutropenic fever, as defined by no clinical or laboratory evidence of bacterial infection, hemodynamic stability, negative cultures, and a low serum CRP, patients were randomized on day 3 to have their antibiotics discontinued or to have their antibiotics continued until resolution of fever and neutropenia. Again, this was a small study, but there were no observed differences between the two groups with respect to proportion of patients who had favorable outcomes, documented infection, and mortality. There are also several observational studies that support a de-escalation approach. In a study by Lernbacher in 2002 among 56 pediatric patients with unexplained neutropenic fever, the institutional protocol was to stop the antibiotics while the ANC was less than 500 if no infection was identified, if the patient had negative cultures and was afebrile for 24 hours, and on antibiotics for a minimum of 72 hours. All of the patients in this study had antibiotics discontinued according to these criteria, and they did not observe any infection-related deaths or complications, no readmissions for recurrent fever or infection. In a single-center retrospective study by Hodgkin's Vidin in 2005, again also of pediatric patients, antibiotics were discontinued when the ANC was less than 500 based on clinical judgment. About half of the patients had their antibiotics discontinued prior to ANC recovery, and 2 patients had recurrent fever and no bacterial infections. In a study by Sheriff in 2004, this was a nested cohort study within an open-label, multi-center randomized controlled trial and included 60 adult patients who had unexplained neutropenic fever. The study protocol was to stop antibiotics after the patients were afebrile for 48 hours, regardless of the ANC. About half of the patients had their antibiotics discontinued, while the other half had their antibiotics continued. They did not observe any differences with respect to fever relapse or mortality. There were certainly limitations to these studies, many of which were small, and likely some selection bias introduced in terms of those patients in whom de-escalation was performed. However, in aggregate, they suggest that early de-escalation may be a safe approach in some patients. Based on these studies, the 2011 European Conference on Leukemia, or EASL guidelines, took a somewhat different approach from the IDSA guidelines. They suggest that empiric antibiotics can be discontinued after 72 hours or more of IV antibiotics among those patients who have been hemodynamically stable since their presentation and have been afebrile for greater than 48 hours, regardless of neutrophil count or expected duration of neutropenia. Furthermore, they underscore the need for antimicrobial stewardship and emphasize that this strategy aims to minimize the collateral damage associated with antibiotic overuse and further selection of resistance. More recently, a randomized controlled trial, the How Long trial, was published in 2017 and was designed based on the EASL guideline recommendations. This was a multi-center study in Spain of 157 patients with high-risk neutropenic fever, mostly hematologic malignancy patients, as well as some hematopoietic cell transplant recipients, who had an anticipated duration of neutropenia of greater than 7 days, and an unknown source, who were randomized to receive either continuation of antibiotics until ANC was greater than 500, or to early antibiotic discontinuation when afebrile, and there was evidence of clinical recovery for at least 72 hours. The primary outcome was empiric antibiotic-free days, and I have highlighted the significant differences in red. The group that had their antibiotic continued until count recovery had a smaller number of empiric antibiotic-free days compared to those who had early antibiotic discontinuation. And although the study was not specifically powered to address these outcomes, there did not appear to be any differences in terms of recurrent fever, infection, and mortality. Notably, there was a higher rate of serious adverse events among patients who had their antibiotics continued compared to those with early antibiotic discontinuation. Since the publication of the How Long trial, there have been several other observational studies that have been published supporting early de-escalation. One retrospective cohort study at Moffitt Cancer Center examined outcomes among patients who had antibiotics de-escalated to prophylaxis versus continuation until ANC recovery, and found a reduction in broad-spectrum antibiotic use in the patients who received early de-escalation. Those who received early de-escalation had to be afebrile and receive a minimum of 5 days of antibiotics. They did not observe any significant differences in recurrent fever, ICU admission, or in-hospital mortality. Another study by a French group, the AntiBioStop study, looked at two cohorts of patients, one where antibiotics were stopped 48 hours after afebrile, and another cohort where antibiotics were stopped at day 5 in each patient, even if they remained febrile. They found no significant differences in recurrent fever or in-hospital mortality, although there did appear to be a trend towards increased ICU admissions among those patients who had their antibiotics stopped on day 5 while remaining febrile. There was a Cochrane review published on this topic last year, which evaluated 8 randomized controlled trials with 662 neutropenic fever episodes. It is important to note that only 2 of these studies were published after 2000, both of which were conducted outside of the US. Half of the studies were published back in the 1970s and 80s. The populations included in this review were also quite heterogeneous, with only 2 studies having exclusively adult patients, 3 having exclusively children, and others having mixed populations. There were different types of malignancies included, with a mix of high-risk as well as low-risk neutropenic fever patients. Ultimately, there were no significant differences seen with respect to all-cause mortality and clinical failure. The author's conclusions and implications for practice are that the results support discontinuation of antibiotics regardless of ANC, but note limitations in the evidence, and that for high-risk patients, one might consider stopping antibiotics on an individual basis, and that further randomized controlled trials are needed. Now, I will summarize the evolution and differences in guideline recommendations on antibiotic duration for unexplained neutropenic fever over the past 2 decades. In 2002, the first IDSA guidelines for the management of neutropenic fever recommended continuing the same IV antibiotics in a patient whose fever had resolved but who remained neutropenic until count recovery. In 2010, the IDSA guidelines were updated and recommended continuing the initial regimen until count recovery as the preferred approach, but did offer an alternative suggestion, albeit with the lowest evidence grade and strength, that if an appropriate treatment course has been completed and signs and symptoms of infection have resolved, that prophylaxis can be resumed until count recovery. The European Conference on Infections and Leukemia Guidelines, published the following year in 2011, took a different approach and recommended stopping antibiotics after 72 hours if the patient was stable and afebrile for 48 hours, regardless of the ANC or duration of neutropenia. Finally, the most recent 2020 NCCN guidelines offer all 3 options, that is, continuation of initial regimen, de-escalation, or discontinuation of antibiotics as potential options for the management of patients who have resolved their fever but who continue to remain neutropenic. Is there a potential role of procalcitonin to guide de-escalation in neutropenic patients? Studies in sepsis have shown a potential benefit of procalcitonin in guiding antibiotic de-escalation. There are very limited data regarding use of procalcitonin in cancer patients. In a study of patients with hematologic malignancy and febrile neutropenia, a procalcitonin-guided approach did not result in any differences in outcomes when compared to standard of care. The institutional protocol was essentially to continue antibiotics until count recovery. There was no significant differences, as you can see, with respect to the median days of their first antibiotic course. They did not observe any differences with respect to clinical cure, infection relapse, or mortality. Further study is needed to evaluate the role of procalcitonin in guiding antibiotic de-escalation among patients with neutropenic fever. In summary, the key take-home points from my portion of this session are: first, vancomycin should not be used routinely as empiric therapy for neutropenic fever with the exception of selected scenarios. Fever alone should not prompt changes in antibiotic therapy in the stable patient without new clinical findings or microbiology results that indicate otherwise. And finally, though there may be selected high-risk cases where a different approach is taken, recent literature suggests that early antibiotic de-escalation is safe and can be considered among patients who are afebrile and who have clinically defervesced prior to neutrophil recovery. Thank you very much for listening to this session, and